This is part 3 of the lecture on tuberculosis and cystic fibrosis. So let's talk about tuberculosis first. Tuberculosis was the great killer of the 19th century, and here's an old poster from the early 20th century when there was a huge public health movement to suppress and to try to eradicate tuberculosis. It was very successful. We had good public health funding in those days. Here you can see the nurse who's sort of heroically hiding behind that child. Nowadays, though, unfortunately, in the last generation or two, with the current government that we had, there was much less money put into preventative health, and now we're seeing a resurgence of tuberculosis. Tuberculosis starts out with the Mycobacterium tuberculosis, which is an extremely tough bacillus. It gets inhaled from another person via droplet. So when they sneeze, cough, sing, talk, something like that. And then it goes to the lungs. In the lungs, macrophages will ingest the bacilli, and two things can happen. I only have one of them down here, so here's the second. One is the bacilli can just die. They're destroyed inside the macrophage, which happens most of the time. But if the disease is going to progress, sometimes the bacilli are tough enough that they actually replicate inside the macrophage. And at some point, the macrophage can't stand all these bacilli replicating inside it and bursts open and will lyse. And in that situation, the bacilli will be released into the lymph or plasma. Now, usually what happens at this point, now we're not talking about a whole lot of bacilli. The person is usually not septically ill or has a huge amount in their system. Usually there's just some of them have released into the lymph or plasma. Most of them will be destroyed there. The T cells in the lymph or plasma will respond to them. And now they're going to go back, these T cells are going to go back to the lung where the majority of these bacilli are. And they're going to create what is called caseating granulomas. Caseating means cheese-like. So it's like, just think of a wet, nasty clump of cheese, and they surround the bacillus. Once the T cells have responded to the bacilli, that is what gives you the positive PPD, that MAN2 test in the arm. So the caseating granulomas that contain the bacilli, eventually they're going to calcify, and it turns into what is known as the Gone complex that shows up on an X-ray, and it's a hardened shell essentially around those bacilli. And now two things can happen. It can simply heal. The granulomas will heal, the bacilli in them will die, and they're just this fibrotic lump that hangs out forever. Or the granulomas can be reactivated. Up until now, everything above that blue line is what you would call the primary infection, and now we're looking at the secondary infection from what's going on below it. So the granulomas are reactivated because now the immune system is down, the person's become immunosuppressed, or they've gotten more infection, they've got more TB bacillus, and their body can't handle it. And now the Gone complex goes through cavitation, which means that it breaks open, and the bacilli are released into the circulation in the airways. So when the bacilli are released into the circulation in the airways, that is when you have active pulmonary tuberculosis. At this stage, the person is contagious, and they will test positive for the AFB, that's acid-fast bacillus sputum test. Now, several things can occur here. One is when the bacilli are released into the circulation in the airways, of course they will usually go to the lungs and cause active pulmonary tuberculosis. They can also go to other areas of the body. They can go to the kidney or the GI tract, the genitourinary system, the fallopian tubes, the joints, the bones, lymph nodes, the central nervous system. They can go to a number of places, and in that situation the person will get tuberculosis in those areas, and that's known as extrapulmonary tuberculosis. It can also go into, when it's in the bloodstream, it can replicate wildly in the bloodstream, which is what we call miliary tuberculosis. It's called miliary because from the millet seed, little tiny seeds of tuberculosis are spread everywhere throughout the body, which of course is obviously very serious. Now the same thing can happen, this doesn't happen very often, but it is technically possible way up here when the bacilli are released in the lymph plasma in the primary stage. If someone is immunosuppressed, they may go right to these. But we don't see that quite so often. So that is the flow chart, so to speak, of tuberculosis. So now let's talk about it in more detail. Tuberculosis was the most common cause of death in the U.S. before the 1940s. But then when we got streptomycin in, we were able to treat it. And like I said, since we've had less money go to public health, between 1985 and 1992, it increased by about 20%, and I assume it's still increasing. This is because of people who are immunocompromised, HIV, we have more immigrants. There's a deterioration of our healthcare infrastructure in general these days, as you know if you read the news. And people are taking incomplete treatment. Before, treatment was monitored to make sure people took their full dose, and now we're sending people home with a bottle of pills and just sort of hoping that they're taking them. And in some cases they are not taking a full treatment, and they end up with what is essentially a super version of the illness. So to go over that chart in more detail in this way, in this format, the primary infection, the risk groups are low-income people, people who all live crowded together, institutional settings, family members of someone who has TB because they're exposed to it, and then anyone with HIV, people who are homeless, and healthcare workers are at risk. That's one of the reasons we made you all get your TB test at the start of the program. The causative agent, of course, is there, the bacterium, the bacillus, rather, Mycobacterium tuberculosis. It's spread by droplet transmission, so you need droplet precautions when you deal with this in the hospital. And the pathogenesis, to repeat it, is the bacilli are inhaled, they overcome the lungs' defense mechanisms, and these get into the lungs, the macrophages eat it up, white blood cells will attach to that macrophage, and then you get that sort of caseation going on. The GON complex will form, that's that calcified thing. The sensitized T cells provide acquired immunity in all the body cells, and that's why you get the positive PPD, the MAN2 test. Usually the GON complex is dormant for the rest of the person's life, but we can get into what's known as the secondary infection, or the reactivated stage. So the people who are at risk for that secondary phase, when it gets reactivated, are the older people, people who are immunosuppressed, people who use chronic steroids, people who are underweight, any major disease essentially, people who do substance abuse, and people who are in close contact with someone with TB because they're very likely to be inhaling that bacillus, people with HIV, and then IV drug abuse. In the pathogenesis, in this stage, the person's immunocompromised. That leads to the reactivation of the bacilli in the GON complex, or else it's just so much repeated exposure to the bacillus. For example, this would be someone living with someone with active TB that there's just a secondary infection being caused. So the clinical manifestations are of the secondary infection, and remember, this is when someone is becoming contagious. It's dyspnea, cough, which is productive for dry, hemoptysis, which means coughing up blood. You don't see that quite as often as you would be led to expect from old novels. People do cough up blood with TB, but that's usually towards the end of the disease. Chest pain, chest tightness, and you'll hear crackles. The person's very tired. That's classic with TB, and so is anorexia. Weight loss. In the old days, this was called consumption for that reason. People seem to be consumed by the disease. A low-grade fever and night sweats. The diagnosis for if there's been an exposure for primary or secondary is the MAN2 test. The PPD, is there a wheal on the arm several days after that stuff is injected under the skin intradermally. There's lots of false positives and false negatives with the MAN2 test. So if it seems positive, that's when we do an AFB, an acid-fast bacillus sputum smear, which is much more exact. And if that's positive, then we know the person has active TB. We also can do a chest x-ray to see if there's any GON complexes going on. The treatment are drugs. 2 months of those 4 drugs put together, and then 4 to 7 months of isoniazid and either rifampin or the other drug. I'm not holding you responsible for these drugs. That's part of pharmacology. Just know that it is a series of drugs that is used to treat this disease. Directly observed therapy means that somebody watches you swallow the pill. You show up to the same place every time you take the pill, and they watch you take it. That's to make sure that people are compliant. We did this quite often with homeless population for over years until the funding got cut, and now they're simply given a bottle of pills and taken off and go off to cook up a super version of the disease, unfortunately. But in some places, directly observed therapy is still going on. And then we monitor the progress over that disease process, over the treatment process with the AFB smear. We see if the symptoms are progressing, keep an eye on that, and do serial chest x-rays. If someone has a latent TB infection, that means they have a positive skin test but no symptoms. Then they just give them isoniazid for up to 9 months or rifampicin for 4 months. And it's important to remember that multi-drug resistant TB and extreme drug resistant TB are on the rise because of the issues I talked about earlier. This is an X-ray, a chest X-ray of a person with tuberculosis, and it shows the GON complex, which is this thing right here. Okay, that's how they tend to show up on the X-ray. And this is just an illustration of widespread TB. The granulomas have gone all through the lungs. So it can become pretty devastating in these situations. Cystic fibrosis is a recessive genetic mutation. So the chances of course, you can see any combination depending on how the dice rolls for your family genetically in this situation. But the most likely, the possibilities are that the person will not have, the children will not have any, will not carry the gene at all, that they may be carriers, or that they may have both recessive genes, in which case they show up with the disease of cystic fibrosis. So a cystic fibrosis, it starts out with a recessive genetic mutation, and that causes sodium to be reabsorbed and chloride to be less secretion of increased sodium reabsorption and less chloride secretion. We're not talking about into the bloodstream. It's not that area at all. This is increased reabsorption and decreased secretion across the surface of the epithelial cells. Remember, the epithelial cells are what produce secretions. The result is that changes what's called the chloride channel, and the secretions everywhere in the body become thick and tenacious, which means they stick. So it's thick, sticky secretions pretty much everywhere. Now that can cause excuse me, a number of problems. In the pancreas, because the pancreas certainly has a lot of secretions, this can lead to, basically, the take-home for cystic fibrosis is everything clogs up with this tenacious, thick secretions. So in the pancreas, you can see diabetes, malabsorption because the pancreatic enzymes are being blocked, vitamin deficiency, and steatorrhea, which is fat in the stool because the lipase is being blocked. In the intestines, you can see obstructions because there's lots of secretions in the intestines, and what's known as the meconium ileus in young children. The gallbladder, you can see cholecystitis, which is an inflamed gallbladder. You can see cholelithiasis, which is stones in the duct. And the gallbladder can become blocked so that the hepatic ducts that coming down from the liver can get backed up, and that can actually lead to cirrhosis. In the genitourinary area, there can be structural abnormalities, infertility can happen. The sweat glands have a very, very hypertonic sweat. So you'll see what's known as the salty baby. The baby would actually taste salty, the skin of the baby. There's a sweat test we use that's called the positive chloride test, sweat test, and it's positive in this situation. And this child can go into hypotonic dehydration. If you remember clinical dehydration a couple weeks ago, that was a combination of dehydration and hypernatremia. In this case, it'd be hyponatremia because the sodium is not going to be reabsorbed into the some sodium gets reabsorbed from sweat, and now that it's all thick and sticky, it can't do that. So in this situation, the child is actually dehydrated and is actually hypotonic because that sodium cannot get reabsorbed into the bloodstream. But the reason we're talking about cystic fibrosis in this lecture is what it does to the lungs, which is one of the most dramatic manifestations of it. The lung tissue gets destroyed because the person has thick, sticky secretions in them, and so they have So these thick, sticky secretions, that the mucus hangs out, and there's all these infections, and the person has chronic infections. And in that situation, the parenchyma of the lung eventually just becomes destroyed by them. So the pulmonary manifestations of these lung attack from cystic fibrosis is chronic hypoxia. Bronchiectasis, that's when the bronchioles become dilated and full of pus. We'll talk about that later. Pulmonary hypertension, which we talked about earlier, because of the pulmonary capillaries are reacting to the hypoxia by vasoconstricting. Cor pulmonale, the right side of the heart, is reacting against that pulmonary hypertension. Respiratory failure, which is one of the main causes of death in cystic fibrosis, if not the main cause. And then you can also see a pneumothorax when the lung simply collapses from this. And once again, we'll talk about pneumothorax more in spring term. This is a picture of bronchiectasis, which is the bronchioles becoming wider and it's filling with pus. So, a longer description here of cystic fibrosis. It's the genetic disorder of exocrine glands. It tends to most often occur in Caucasians. It's very rare in African Americans or Native Americans, and it's pretty much unheard of in Asians. And this is the hypersecretion of abnormal thick mucus that obstructs all the exocrine glands and ducts. And the mean survival age is about 31 years. So it's an autosomal recessive disorder like we talked about. The CFTR gene is mutated and is abnormal and results in the alteration of chloride and water transport across the epithelial cells, which is where secretions are made, of the pancreas and all those other areas. The mucus from the glands it's excessive secretions, and it plugs glands and ducts, and it causes dilation and then fibrosis. And the lungs, the mucus there is thick and tenacious, and we get airway obstruction. And then we get the things we talked about, atelectasis, hyperinflation, decreased ciliary action, so then we get mucus stasis. And whenever you have mucus hanging around, it ends up being leading to infection. So the clinical manifestations of the child has a history of a cough. There's thick, tenacious sputum, recurrent lung infections. The most common one is Pseudomonas aeruginosa. And you can get to this can lead to pneumonia, bronchiectasis, right-sided heart failure, like I already said, and then of course exercise intolerance. You'll see digital clubbing. This is a picture of digital clubbing. Here it is down here. The one up here is normal. Usually in a person who does not have a respiratory disease process such as this, there's a little diamond-shaped window when you put two nail beds together and hold them up to something light. You can do it now and see. Hold it up to the computer. You can see a little diamond shape between the nails there. With clubbing, that goes away because what's happening is here's mild clubbing and here's advanced clubbing. There's just a change in the structure of the tissue because of lack of oxygen to the extremities. So you will see clubbing in the child with cystic fibrosis. And then you will see these signs here. The clubbing, the dyspnea, the tachypnea, sternal retractions, and so forth. A barrel chest and the crackle sounds and all the things that I've written down here. The diagnosis is ABGs and PFTs. Once again, you don't need to know the exact values. Just know that those tests are used in cystic fibrosis. Sputum culture and sensitivity, and the chest x-ray. And because of the issues of cystic fibrosis in the intestines and the pancreas, they'll do a stool exam for fat. They'll do the chloride sweat test we talked about. And then, of course, there's genetic testing once you realize this is what's going on, because the family needs some counseling about future children. And the treatment, of course, is interdisciplinary. There's an aggressive pharmacological management of pulmonary infections, and we use bronchodilators. Once again, respiratory therapy. We'll do chest percussion and postural drainage. And these drugs, which, of course, remember, I'm not testing you on, but they'll use recombinant human deoxyribonuclease 1, high-dose antibiotics, annual influenza vaccine, unrestricted fat consumption because the person is not processing the fats and so then needs more in the diet. So it's very rare to have the high-fat diet, but this would be one of the situations where you see it. Pancreatic enzyme replacement to be able to handle those fats. In terms of what's most at risk for this child or young adult is usually the lungs. And they may do a heart-lung transplant, and I don't really have it written down here very well. I should have. Sometimes it's just a lung transplant that they'll do, and that's the only really definitive treatment at this time. But people with cystic fibrosis are living longer, and so it's not as hopeless a disease as it was 30 years ago by far. Diffuse interstitial lung disease, this we're just going to talk about briefly. One thing I've noticed is, I want you to cross out of this line. That must have been a note to myself. I didn't really tell you what the etiology was, so I'm going to tell you now. And there's a number of these. I'm going to say these slowly so you can write them down. This can be caused by silicone dust, by asbestos fibers, by grain dust, by bird or animal feces, by radiation, and that includes radiation treatment. Chemotherapy can cause this. There's a huge number of drugs that can cause this condition. The disease lupus, which is abbreviated SLE, systemic lupus erythematosus, that can cause this. That's an autoimmune disease. And rheumatoid arthritis, which is also an autoimmune disease. Quite often this occurs simply from an unknown reason. So those are the etiologies. I'm not simply going to read through all these paragraphs because you can read through them on your own. But so the take home with diffuse interstitial lung disease, which often is just called interstitial lung disease, is this is the body's repair process gone into overdrive. Because of those etiologies that I just talked about, the body goes into there's basically three big patterns. In the alveolus, there's inflammation from those etiologies I just talked about. They then get fibrotic. That's the second pattern. And then there is destruction. So really, irreversible fibrosis is the easiest way to think about this disease. The clinical manifestations are progressive dyspnea with a non-productive cough and rapid shallow breathing. This is a disease where it's hard to breathe in. Dyspnea, nail clubbing like we talked about. In both bases, you'll hear end expiratory crackles known as Velcro rails. That's what they sound like, Velcro being torn apart. And extreme dyspnea with exercise. And later in the disease, you'll see cyanosis, and you'll also see anorexia and weight loss. The chest X-ray shows a honeycomb appearance and what they call ground glass haziness, and those are the infiltrates. That's the fibrosis that once it's there will never go away. This is a X-ray, chest X-ray of a person with interstitial lung disease. You can see they left their jewelry on actually around there. But you can just see everywhere that sort of hazy look, and those are the infiltrates. That's fibrosis. And of course where fibrosis is, then alveoli cannot exchange oxygen. Occasionally they will do a lung biopsy to see what's going on here. And they will do pulmonary function tests, which will show, of course, an extreme limitation on inspiratory and expiratory reserve. The treatment is to avoid tobacco, which is true for any respiratory condition, but certainly true for this one, and environmental exposures, if those were the issues that caused this. And we give anti-inflammatory and immunosuppressive drugs, sometimes the corticosteroids. And some patients, if they qualify, will get a lung transplant. So that is part 3 of the lecture on tuberculosis, cystic fibrosis, and interstitial lung disease. Next, we're going to talk about the rest of the diseases.